If my maths is bad at any point, I apologize. I have been a bit busy, so I didn't actually check over my maths. Fine. So there's a few spot diagnoses. There's a few like general prescription things. We'll do more specific prescribing over the next few weeks, just because it does come up, and I think it is worth going over. But this is like the first tier of knowledge you need with regard to prescriptions. Sorry, someone just needs to be added to this. Fine. So let's start off with some non-prescribing medicine-y things, because that's like the fun bit. So this is, does anyone want to tell me what we're looking at? You can guess. If no one is able to come up with anything, then I will give you a clue. Yeah, so these are the ventricles in the brain, and what kind of scan is this? This is an ultrasound scan. So immediately, if you know that we're using an ultrasound scan, what does that mean? What do we know about the patient? If we're using ultrasound as a modality, yeah, small patient, yes. So likely a neonate, definitely pediatric, but yeah, pretty much definitely a neonate. And what is going on in the image on the right? It's actually both of them, but it's more obvious on the right. Yeah, intraventricular hemorrhage. So this is what it looks like. Here, it's kind of a spot diagnosis if it ever comes up in an SBA. Risk factors for intraventricular hemorrhage. Ventouse delivery, prematurity. Yeah, generally any instrumental delivery. Lack of vitamin K deficiency. Yeah, those are like the main ones. And yeah, so yeah, if there's some form of asphyxia during pregnancy, that later needs them to require oxygen, that is also a risk factor. Anti-epileptics, I think I don't quite understand the mechanism, but I think there is some correlation between those as well. Does anyone know the mechanism for that? Actually, let me have a quick Google. And what can you give? Well, I googled that. What can you give to reduce the risk of intraventricular hemorrhage? So yeah, you can give vitamin K. There's one other thing you can give. Yeah, so you can give vitamin K and you can give magnesium sulfate. Yeah, so you give both of those things uh to do that. Cool. And then there's lots of complications of intraventricular hemorrhage. It's all on the next slide, so don't worry that I'm talking. Actually, let's go. So yeah, it's like where you have a bleed from this fourth ventricle caudate nucleus. Do you give magnesium sulfate to the mum before labor or to the baby? I think you generally give it to the mother, because I remember like one of the consultants saying it's basically a two-hit thing. So you have so especially in the context of like a preeclampsia, you not only give seizure prophylaxis, but you also give you can also reduce the risk of intraventricular hemorrhage. So it's quite a good. Magnesium sulfate is just like a really great drug. Do you give vitamin K routinely? It's a good question. I can't really remember. Let me get back to you on that. In the meantime, what are the complications of intraventricular hemorrhage? Yeah, I think you do. Um, I can't remember when. Do you remember when you? Is it just immediately after birth? Oh, I love crowdsourcing knowledge. I think you immediately give vitamin K in this country. Yeah, as soon as they're born, you give them IM K. Yeah, good stuff. Complications of intraventricular hemorrhage. There's a few important ones. Yeah, there's a risk of cerebral palsy. Yeah. Hydrocephalus. What kind of hydrocephalus would that be? Yeah, it's like an obstruct. Yeah, you get like an obstructing hydrocephalus. Jaundice. Yes, any kind of bleeding can eventually cause a bit of jaundice. Yeah. What else? Anything else? I guess the other things are just like related to cerebral palsy. So they did pay, like these kids might present with like a developmental delay. Coning. So coning tends to be a bit less common. A mass effect is less common in kids. It would have to be a massive hemorrhage, and like because the fontanelles can expand, it's a bit less likely. But yeah, these are like yeah, you diagnose with ultrasound, you get parenchymal damage, and then yeah, you can get cerebral palsy due to that parenchymal damage. I don't know why I put that question with the answer on the same slide. Good. So yeah, remember, give them Vit K as soon as they're born, and if it's a preterm birth, you will probably give magnesium sulfate to reduce the risk. Uh, what's going on here? Yeah, this is normal skin in a preterm baby. Again, you might notice a bit of a theme. We haven't really covered premature like baby stuff a lot, so I've been trying to do it over the last few weeks. But yeah, effectively, the skin is quite interesting. So keratinization happens approximately a week after birth. Even that's when it kind of completes itself. So you get like this when they're premature, the process has only just started, and they can get like this really permeable skin. Do you know what that means in terms of our management of preterm babies? What's the issue if they have very permeable skin? Yeah, they'll get dehydrated, they lose heat, they lose water. So yeah, this is why we incubate and we have humidified incubators, and that's like the most important thing to think about. That's kind of the one of the big reasons we do that for kids. Yeah, and then if they have any weird electrolyte disturbances, the neonatologist will correct those. But that's like a decision way above us. What's going on here? Again, going on with our theme. Yeah, this is necrotizing enterocolitis, and yeah, the sign, as James has said, is pneumatosis intestinalis because there's gas effectively like within the on like there's very edematous bowel, so you can see gas very clearly. How can you tell this from malrotation? Right, let me get you an image of malrotation. CXO. And you can tell me the differences between the two. Sorry, just 1 second. So, malrotation, I'm going to put an image in the chat. So this image is malrotation. So as you can see, like most of like the small bowel is actually shifted to one side, and you need to effectively they put these bands in. I can't remember what they're called. If anyone remembers, can you let me know in the chat? That effectively keeps everything in the right position, opposed to like being turned around the wrong axes. Lad bands, that's it. Yeah, lad bands. Let me find a pneumatosis intestinalis example. So here we go. This is on an adult X-ray. So it's but these arrows basically point out where the gas in the bowel wall is. So lad bands are like the surgical correction of malrotation, which is one of these structural problems that babies can get. Harvey, can you see the so this is gas within the mural wall of the intestines. It's quite hard to see in this X-ray of this baby, but it is a feature of necrotizing enterocolitis as well. I will get you a picture of the lad band surgery. Give me just a second. That was a very good image. I can't find it at the moment, but I'll send one at the end just for the sake of time. Thank God for arrows, I know. Tell me about it. So when you see like a baby with like neck, what are like the signs and symptoms that you might associate with it? So distension, yeah. So you can split them into local and then other GI symptoms and then systemic. So local, you get distension. Other GI symptoms, yeah, bloody stools, bilious vomiting, yeah. Yeah, and often it can be quite tense if there's like a lot of gas. Enough to need transfusion. So it does depend. Hopefully not. So it really does depend on the severity. You can get different severities of neck, but the one case I saw, they didn't. They didn't need transfusion. Might be febrile discoloration, skin thrombocytopenia. These are all really good ones. Yeah. How come? And then systemic, they can get hypertension, hypothermia, failure to thrive. Kids present very non-specifically, much like the geriatric population. It's all a bit rogue. How comes they're not more constipated? They're not really constipated because there's no like it's not fecal loading. It's just there's a ton of gas in the abdomen because there's basically lots and lots of inflammation, and the gut bacteria will end up like producing lots of gas. I think it is also a cause of hyponatremia, but I can't remember off the top of my head. Josh, you might be right. Sorry. Management. So would you jump to surgical management? Yeah, probably not. Gut rest is like the absolute like priority. Yeah, hyponatremia, natremia is one. Sorry, I was just checking, but yeah, it is. So yeah, you've all got like the right idea. So you're going to switch into parenteral feeding. So you're resting the gut. You're not going to drip and suck because drip and suck is for obstruction, where you're going to put an NG tube in, but you're resting the gut. So you're finding other routes to provide nutrition. And then like if I was to ask you to cover if I wanted 3 different antibiotics to cover the potential infections, what kind of stuff could you give? So yeah, you don't use the NG tube to feed. You'd consider putting an NG tube in order to aspirate gas and like reduce the tension. So you're reducing the risk of perforation. So as usual, there is always like a antibiotics are always more an art than a science, but there are lots of different options. The point is you just want to cover gram positive, gram negative, and you want to cover anaerobes. So I'm just figuring out whether Liang's is quite good. So if Metro would cover anaerobes, cephalosporin would probably cover both gram pos and gram negative, and then Vanc would cover like any staph. You probably wouldn't need you wouldn't need you might not actually need the vanc with that. But yeah, so just make sure you cover all three. This is what I saw being used a lot, but like it really depends on local policy. Just have a look at what they're giving, but they will cover all three possible like groups of bacteria. Cool. That makes sense. And yeah, parenteral means IV feeding effectively. It's quite unpleasant. You want like you need like a wide bore vein to access because you can't really give it through peripheral veins, but it's quite tricky in like babies because all of their veins are quite small, even the central ones. If you have any questions, ask them. What we're going to do next is we're going to do this case. So I forgot to include the clinical context because I was clearly tired, but this is a gentleman with metastatic prostate cancer who's palliative. This is his current pain requirement. You want to convert him to a syringe driver as he's finding it very difficult to swallow tablets now. Have a go at prescribing a syringe driver. We covered this it might have been a few months ago now, but I have like a good worked example that I can show you. So I'm going to give you 5 minutes to do this because this is how long you'd have to do it in an OSCE. I wouldn't be surprised if they paired this with like this could be an integrated station if it was longer. So the way my firm and I practiced this year is we practiced it as a 10-minute where you discuss palliative care with a relative and then you prescribe anticipatory meds for someone who's deteriorated. So I wouldn't be surprised if it was like an integrated station because that's like UCL's jam. But have a go. And then I'll go through the answers in 4.5 minutes. Again, this is more an art than a science. There's lots of different ways to do this, but there's just some general principles to follow. Obviously use the BNF or NICE CKS because they'll in an OSCE they'd absolutely give you access to the BNF or some local guidelines because it's harsh to just memorize things. You've got just under a minute left. Okay, that's time. So yeah, this is one of those things where once you've been over it, like it's quite simple to do in 5 minutes, but like no one, like it's quite complex to get your head around in the first place. So this is what I went for. So the important thing here is converting the morphine to a more suitable dose that can be given subcutaneously. So he's on 80 milligrams twice a day PO. So that's roughly so if you check the conversions, you need to half that in order to get the IV or subcut dose. So he's 40 milligrams a day. Haloperidol you can get from the BNF as this many, so you can use that for both as an antiemetic and as an anti-anxiolytic. So it kind of kills two birds with one stone. It might not suffice on its own as an anti-anxiolytic. You might need to add something like midazolam in reality. And then choosing something that is anti-secretory, you can pick. Well, we can talk about some of the other options you might have picked in the next slide or so. So you put all of these into a syringe driver. For your exams, you put these into a 24 mil syringe, so you can just give it at 1 mil per hour over the course of the day, and it's subcutaneous. It's not. It doesn't go into a vein. It's just going underneath into the subcutaneous fat. In reality, good luck getting a 24 mil syringe, and you would either get a 30 mil syringe and waste like that syringe that's too big for it, or you just put it through a 20 mil syringe. Does anyone know what the maximum number of drugs you can mix together in one syringe driver? It kind of depends on what guidance you look at. Yeah, but I think four is the one that's quoted for UCL. So yeah, don't mix more than 4 different drugs. Some places say 3. There's a few things that cannot be made with water. So have a look. You obviously would look through what medication you're using before you do prescribe it. If you were adding PRN doses of morphine for the breakthrough, would you put these in the PRN section or would you write them in the infusion section? So PRN doses, you would just write as PRN. You put in the PRN section as subcut morphine injections for PRNs, because it's not an infusion that's running over 24 hours or anything like that. Yeah, so haloperidol can cover several things. Haloperidol has antiemetic properties, and it also has anti-anxiolytic properties. So you might or might not need to give other things with it. I'll get onto this stuff in a minute. So if we look at the anticipatory meds, the other option. So you need to make sure they have some form of analgesia, morphine or some kind of alternative, depending on the renal function and things like that. Anxiolytic, you can use haloperidol, you can use midazolam. Secretions, you can use hyoscine hydrobromide, butyl bromide, or glycopyrronium. It doesn't really matter. Pick one of them. And then as an antiemetic, you can use haloperidol, or you can use things like cyclizine. Probably don't use things like metoclopramide because they'll have bowel involvement if they're terminal. So it might be a bit dangerous to use metoclopramide, but yeah, cyclizine might be quite good, depending on their past medical history and things like that. Right, let's go through some of these questions. What is the choice of laxative or antiemetic? So in terms of anticipatory meds, often you don't actually need to prescribe a laxative. If you do, you're more likely to give something osmotic than stimulant, because stimulant might be an issue if they've got metastatic bowel cancer, but they generally won't ask you to prescribe a laxative as part of anticipatory medications. Would you give them PR, or is there a subcut form? Yeah, so that's the issue with laxatives. Usually constipation is just not an issue when you're getting to end of life, but there isn't really a subcut form because it won't really help that much. So you'd ask a senior, if I'm honest. I'm not too sure about. So what I've seen is some people give something to like soften the stool, PR, and then try some, and then give something that will work orally, even though they don't really have the oral route. I've seen doctors try that out because there's not that much you can do if you don't have the oral route. Glycine chips is what I was told as well, actually, Paulina. So that's what I've seen. But yeah, I think that's like a bit above our level. Again, I think you'd talk to someone else before you did something like that. Just checking, will the school expect us to form 2 different forms of laxatives and antiemetics? Probably not. I don't think I was taught that, actually. How would you rationalize which anticipatory meds to use if the stem is vague about symptoms? They will give you all the marks as long as it makes sense. It doesn't matter how vague the stem. Like if it makes sense and there's no contraindications, you can give it. Morphine is the only one that needs to be re-prescribed PRN to, or you can prescribe if it's not enough. If what you're giving isn't enough, you can add stuff on into the PRNs. In real life, you will add stuff onto the PRNs if they're feeling really sick. With the dose ranges on the BNF, how would you pick? In reality, look at their body habitus, see what their renal function is like, and decide based on that. In an exam, it doesn't really make up. Just kind of pick one. Doesn't really matter. Is there a particular reason to pick hydrobromide or butyl bromide? Hydrobromide is usually a bit better so butyl bromide is really good, is Buscopan. That's best for like bowel symptoms. Glycopyrronium and hydrobromide tend to be better for respiratory secretions. Does it really matter what you prescribe? Not particularly. Why was the hyoscine prescribed? Yeah, so anticipatory meds, you always generally prescribe some form of secretion thing. They will probably give it to you in a stem, so Tapan, you are somewhat correct. PRN morphine every 4 to 6 hours. You can give it more in palliative care if you need to. That being said, if you're giving it more often than that, they really need a better dose titration. But yeah, 4 to 6 hours is a good bet. How many anticipatory meds? You need to cover all 4 of these things. You do need to cover all 4 of these things. So you can't just give 2. I would give something to cover analgesia, an anxiolytic, secretions, and an antiemetic. Remember that these drugs are often this is in case stuff deteriorates and they're like nearing the end of their life. So last 24 hours, which is why laxatives aren't really an issue. Like if they're going to die within the next day, laxatives aren't really like a huge driver medication. It depends whether or not, like, just look at the BNF and see. That's why I avoided using cyclozine, because I know that it interacts with some other drugs. It doesn't particularly matter in an exam. I think they're more worried about you looking at what kind of drugs can you use and making sure you're addressing all 4 of the main issues. Would you give 5 milligrams PRN or 6.6 milligrams? Yeah, I think I'm going to let you figure out the answer to that question, Nandish. I think you do know the answer to it. So in our finals OSCE, we had access to the BNF app and basically anything on the BNF app. Treatment summaries, I think it's difficult to say. If you have an online if you have the BNF app, I can't remember whether the treatment summaries are on there. Let's have a look. They are on there, right? So palette. Can someone else check because I'm slow? Yeah, they are. So like if it's the app, you'll get access to all of it. And I think they are moving to using the app more in exams because no one uses the paper BNFs anymore, except for like the odd GP here and there, like my GP tutor. Fine. Any other questions? Because I'm happy to spend as long as we need to I'm happy to spend as much time as we need on this because like if it comes up, it's like a station you can do well on. Generally, like there's lots of options, so it'll be quite easy as long as you cover the 4 big issues. And remember, anticipatory meds are for people that you expect to die within the next hours to days, or you'll have them prescribed and ready to go in case they are deteriorating in the community. It's to make the passage of life as anxiety free and pain free as possible. So just think about the things that you need to do in order to do that. Maybe a dangerous age to start looking at summaries, though. Yeah, I agree. I do agree. I would. So morphine, they'll give you a conversion. VTE prophylaxis, probably unnecessary considering they're about to die. OSCEs, yeah, tends to, well, right. There'll be one that's in 4th year for us, it was 1 station. In finals, there was a bit of prescribing as a component of several stations. So there was one, I'll tell you after because I shouldn't, I'll tell you later for obvious reasons because there's a recording. If there are other regular meds prescribed in the chart, are you expected to cross them out when you rationalize? Yeah, so it depends. If it says adjust their drug chart accordingly, then yes, you would. In this case, it was just prescribe anticipatory meds. But if they've lost the oral route, you need to find another way of giving them, or like realistically, because it's palliative care, you're probably going to stop a lot of the medications. Did you just mention we could be given the conversion tables? I have a feeling, like, obviously I'm speculating because I haven't had this station as an OSCE, but like, I feel like they would give you the conversion tables because there's a lot of discrepancy between lots of different sources on the conversions. There's a few that you kind of need to know, like morphine, oral to subcut, 2 to like dividing by 2 is very reasonable to know. And if that's the only conversion you need to know, like they ask you to do, then I think that's fair game. The other ones probably less so. Because things like tramadol and when you're converting between weak and strong opiates, like that kind of stuff does vary a bit. Any other questions? So remember, anticipatory meds is the very end of life. This is what you're giving. There is this opioid conversion table on the summary, but like there's that conversion table, and then like the resources UCL gave us last year had a different conversion table, which is why I think they'll tell you what to if there's any like specific conversions they want you to do, they'll tell you about it, I think. Cool. Anything else before I move on? Sorry, the slides are in the wrong order, but I'll fix them. We're going to do a bit more prescribing because you didn't have an OSCE last year, and we'll go over some stuff that like is still relevant to 5th year, although I think it is less likely to be examined but I think it's worth going over regardless. So we're going to do some adult fluid prescribing to start with. So Mr. Ismail is a 78-year-old gentleman. He's currently nil by mouth, and the anaesthetist has asked that you prescribe his maintenance fluid for the next 24 hours. He weighs 72 kilograms. Please prescribe appropriately. Do you write any extra notes, e.g. bleep if pain not sufficiently controlled? I would. In real life, I would write that. And I've seen my F1 this year write that every time he's prescribed for palliative care. I think that's a very good thing to write. So I've been nice enough to include this table of concentrations of different ions. But I feel like in endoscopy, I don't think they'd give you this table. Again, fluids are more an art than they are a science. There's lots of different ways of correctly prescribing. I generally, in an OSCE, tend to only use I tend to only try and use sodium chloride, Hartmann's, and Dextrose, because you never know what kind of trust you'll be working in. Because some of these other things, like Dextrose Saline, is very good, but like, will you have access to it? Who knows? Would you get spare paper to do the quick calculations, or this is all mental arithmetic? There will be paper. There's paper in pretty much every station you have to write in. There's paper in most stations you don't need to write in as well. So don't worry, you'll get spare paper. There might even be a calculator there, if you need to calculate anything. So for this station, like I wouldn't be surprised if there was a calculator. It'll be a stupid like calculator though. It won't be like it won't be scientific. I'm gonna give you. Sorry, I've been nattering on. You can have another 3.5 minutes to do this. I just one other thing while you're doing this that I forgot to mention. Mouth care is very important in palliative care. Even if they're not eating or drinking, making sure that like they get the droppers or ice chips in order to stay comfortable, very important. Otherwise, like it can get like it's not very nice for them. So yeah, just keep that in mind. Do you prescribe that? That's a good question. I don't think you prescribe that. I don't think you do. I think that it's something to tell the nurses about, and they can help with that. I don't think you necessarily prescribe it. To be fair, you can technically prescribe anything. Yeah. Yeah, I mean, in an exam, you definitely wouldn't prescribe it. In real life, you might. It depends on your trust and what drug chart they're using. I have a fun story about this. Someone in the year above who's now like an F1 super wholesome guy. I told if Jack's here, I was telling Jack Hennessy about this, and he effectively. There's this lady who's really lonely on his ward. So on his drug chart, he prescribed 2 daily phone calls with the lady's daughter, so she would be less lonely on the ward. Some people are just like too pure for this planet, to be honest. Yeah, I know, right? Yeah. So you can prescribe whatever you want. You'll probably piss off a pharmacist, but like, you do what you do. Fine. You can 30 seconds, and then we'll go through this. Okay, fine. So for an adult, this is some year 4 revision, hopefully. For an adult, what are the requirements of an adult uh, when prescribing maintenance fluids? So what are there's like 4 things that we need to do. So you want 25 to 30 mils per kilo per day of water, 50 to 100 grams of glucose, and then you need to adjust for the electrolytes. Yeah, so yeah, you want 1 mil per kilogram of sodium chloride ions and potassium. And the most important one of those, I didn't even put chloride on because I never like pay attention. That's really bad for me. I should pay attention. The most important one of those, the electrolyte, is potassium. Potassium is the one that can cause a bit of havoc in the body. So yeah, don't forget. I would focus on about adjusting the potassium. They're very generous on the chloride. They can be very generous on the sodium as well. So like those two are less important, but the potassium you need to be very careful with. So I wouldn't worry too much about sodium and chloride. If you give someone too much sodium chloride, what metabolic abnormality do they get? Yeah, they get hyperchloremic metabolic acidosis. Yeah, that's the one. So I've done the calculations here. So you need around 72 moles or so of sodium and potassium. And why have you said oops? Have you been giving everyone like a ton of sodium chloride? You need around 2.1 liters worth of water, and you need the glucose is the same for everyone. So what does this look like? So this is what I went for. The arrows will make sense in a minute. So I went for 5% of dextrose, which gives you 50 point, and then I gave a liter of normal saline, and then I gave 100 mils of dextrose in the most useless fluid bag ever. I can't believe I wrote that over 8 hours. Sorry, that should not be over 8 hours. That should be over like half an hour or something. So that gives you 100 grams of glucose in total. It gives you around 150. It gives you around 150 moles of sodium, which is too much. You could probably just skip the 100 mils, but I put it in because someone would be like, oh, they haven't got the right amount of water. You could definitely just skip that. I don't think it adds anything. And then you add 80 millimoles of potassium. I think it's close enough to 72 where it doesn't make a difference. There is a risk that you could give them hyperkalemia, but you could round it down you could round it down to and just give 40, or you could give like a more specific amount. Could you round to 2,500? So this was quite an elderly person, so I think I would be a bit. I think you probably could, but depending on their history, you'd want to be careful. Again, all of these are considerations that like it's good to make it's good to think about all of these. In reality, it's probably safe to do it. How much can you overshoot potassium by? Not a lot. I think I put two lots of potassium because I think 80 is probably like the maximum you could, like, that's rounding up by 10. If I had to round out by anything more than 10, then I'd probably say no. Uh, can I put 40 millimoles of potassium and then 20? Yeah, that's probably even safer. Is it generally better to over or undershoot things? As long as it's within reason, it doesn't really matter either way. Would it be still correct if you go for 25 mils of water per kilogram? That's fine as well, as long as it's within the limits. Do you go along with the rule of 1 liter equals 1 hour? So if you give half the bag, give it over half an hour. Yeah, you can do that. 1 liter over an hour is pretty good, unless they have something like pulmonary edema. Can you give 2,000 mils, or would you be specific with 2,100? You could give 2,000 because basically it needs to be within the range of 25 to 30, ideally, and that's within the range. So you could just give 2 liters. What's the difference in glucose amounts in 5 and 10%, which is used when? 5% is what I would generally use for prescriptions. 10% is more when you're correcting hypoglycemia, things like that. But if you're just using maintenance fluids, I would use 5%. Would you be able to give 2 bags of saline rather than dextrose? So you can't just give the saline, the saline, because you wouldn't be they wouldn't get their glucose they wouldn't get their glucose requirement. So you do need to give a little bit of dextrose. Do we need to memorize what the different solutions contain? Memorize, no. Have a rough idea of, yes. So you need to know that sodium chloride has a lot of sodium. You need to know that dextrose, you need to know roughly what they have in them. Could you repeat why it's 8 hours? It's 8 hours because that's what's generally done in real life. 1 liter over... Wait, did I say 1 liter over an hour? 1 liter over 8 hours is like a standard dose for a standard infusion rate for a liter bag for maintenance fluids. Basically, you take the total amount, and in an ideal situation, you would give it over 24 hours. What you will realize in real life is you do not give fluids over 24 hours because you don't want them to have fluids going through them while they're asleep. So you might give it over 16 hours or so, but basically just split it over the 24 hours for exams. Yeah, if you're prescribing 500 mils, you could give it over 4 hours. You can technically give fluid as fast as you want. You just need to make sure that you don't fluid overload them. You could give 500 mils over an hour. Wouldn't the 50 grams in 1 liter bag of glucose be enough? Yeah, I think Vikram's question was, could you not? I can't remember. Was it Vikram's question? Sorry, I need to find it. Someone's question is, why can't you just give 2 liters of... sorry, I can't find the question I was reading. 2 bags of saline and then no bags of dextrose was the point, and then you wouldn't get any dextrose. But yeah, 50 grams in 1 liter bag of dextrose would be enough. Could you not give 2 1-liter bags of dextrose with potassium and 500 mils of saline? That is also something you could do. You're probably overshooting the fluid requirement a tiny bit, but yeah, you can do that. You can absolutely do that. This is what I mean. You can get away with a lot as long as what you do is logical and they can see why you've done it, which they will be able to because it's prescribing. Because when they're marking you, they're going to go through and mark based on the ion concentrations what you've done. It's not really an issue. There's lots and lots and lots of correct ways to do this. Could you give 1 liter sodium and 2 bags of dextrose? So if you give 1 liter of sodium and how much dextrose are you giving? It depends. So if you're giving 2 500 ml bags of dextrose, then you're only giving them, these concentrations these amounts on this table are per liter. Sorry, I can't find it. These are per liter. So if you gave if you give 2 bags of 500 mils of dextrose, they'd be getting 50 grams of dextrose, which is actually enough. So you can do that as well. You just need to make sure that you add you need to make sure that you give them potassium with something as well. Is there a reason I gave dextrose first? Absolutely not. I didn't. I don't know why. It was just the mood I was in. Can you give 10 millimole bags of KCl, or do they come in 20 and 40? I think they come in 10 as well. I think you could adjust it. When you work out the prescription, do you bother working out the amount of sodium and chloride? I personally don't, because as long as I'm not, I work on the potassium, the glucose, and then I adjust everything else. Overshooting the sodium, not really a big deal. Like, as long as you're not going over like 150 a day. Overshooting the other things, the potassium, big deal. Can you add the potassium to the dextrose? You can absolutely add potassium to the dextrose. There's no interaction. There is someone watching you on a prescribing station. It is unlikely that talking through what you're doing will make that much of a difference. Depends on the station. If you give 500 mils of sodium chloride, would it have 75 millimoles? Yeah, exactly. So if you halve, these are all per liter. If you halve any of them, you get half of the ion that you're doing. So if I guess if you want to be perfect with the potassium and you want to be perfect with absolutely everything, you could give because there is a difference between being perfect and prescribing for real life. I've unfortunately gone for a bit more of a real life approach, but I guess you could give a liter of dextrose, which would give you 50 grams of glucose. And you would add 40 millimoles of potassium into that. Then you could do a 500 ml bag of dextrose, which would give you another 25 grams of glucose. So they're at 75, and then you could give them something like 20 millimoles of potassium in that. And then the last 500 mils, you could use sodium chloride in order to make it up, and that way you're not overshooting the sodium either. So there's lots of different ways to do it. Do stat fluids go in the infusion sections or in the PRN? Depends on the trust. For your exams, I would put stat fluids in. I would put it in the immediate emergency prescribing section, but it doesn't really matter. They should give you the mark instead. Do you write review in 24 hours in the infusion section? No, because you're going to review their fluids after 24 hours regardless, because you won't have prescribed anything. You would probably add it to the jobs list instead. Any other questions? Is it unlikely that we'd prescribe stat or rhesus fluids? I don't think it's unlikely at all. They could ask you to do that in the context of an ATE. Would you prescribe thromboprophylaxis? Yes, in reality you would, but you weren't asked to do it in this situation. They'll tell you what to prescribe. It'll be very obvious. They'll tell you when they want what they want prescribed. But yeah, I think it is a good idea. It's good that you're thinking about that. I should have specified maintenance fluids. Oh wait, yeah, it says maintenance fluids, but yeah, in reality, you would require thromboprophylaxis. In an emergency, do you prescribe first or administer first? Administer first. You can prescribe later. Infusion or PRNs. So I don't think you mean the PRN section. I think you mean the emergency, like the stat prescription section. In real life, you generally prescribe in the infusion section, even if you're doing a 500 ml bolus. In your OSCE, you can put it in like the stat section, or you can put it in the infusion section, and it won't make a difference. They will give you the same amount of marks. But I would, if it was an ATE situation, I would put it in the stat section. So do you only prescribe what they tell you, even if they know other things? Yeah, basically in year 4 and 5, that is generally the case. In finals, it changes a little. They'll be a bit more vague. If you have spare time, there is no reason to go and not fill out the other stuff, though. It might be good. Like, it is good to do the other stuff regardless. Adrenaline is like 100% you administer and then prescribe. Would you put patient info at the top? You should, but funnily enough, they often give you printed patient info in your OSCE, so you don't get sometimes you don't get marks for that. if you give 500 mil dextrose, is the max KCl 20 millimoles. So it depends how quickly you're going to give it. What's like the maximum rate at which you can infuse potassium on the ward? If the ATE situation is a 5-minute station, then they're not going to ask you to prescribe as well. Yeah, so you can't give potassium on a normal unmonitored bed at more than 10 millimoles an hour. So if you're going to give 500 millimoles over 4 hours, you can give 20, no problem. If you're going to give it over 2 hours, again, no problem. If you're going to give it over 1 hour, then you can only give 10. So like it depends more on the infusion rate. How would you pick between dextrose and dextrose saline? I always pick dextrose because dextrose saline isn't available in every trust. Like Barnet barely had any dextrose saline. But it doesn't make a difference. Like you can pick either. It's up to you. I think dextrose saline is actually really good. I think people really like it because I think it's way more comfortable for the patient. But yeah, it depends on trust availability. Any other questions? God, I underestimated how long this would take. I have 2 more prescribing cases. We can do them another day, or we can do them today. I'll let you guys pick. Wait, so let me make a quick menti and you can vote. I can't be bothered doing the menti. Continue. Right. If you want to continue, thumbs up this one. If you don't want to continue next week, you've got 2 choices. Pick one of them. Just react to one or the other. Either way, it's recorded. And we'll do more of this because and if there's like a bit of a split, we'll do one more and then we'll do something else later. I'll wait 1 minute and then I'm gonna go. Fine. Okay, I'm gonna suggest a compromise. Let's do one more bit of prescribing, and then we'll come back and we'll do more stuff next time. So we're gonna do this case. This is a bit of a short thing, but like pediatric fluid prescribing, they can ask you about bolus fluids or they can ask you about maintenance fluids. The main thing they want to know is how much fluid you're going to give them or how quickly you're giving them fluid, because it can cause issues in terms of physiology. So we'll do this and then we'll do some more prescribing next week because I feel like you will want more prescribing. Yeah, okay, fine. We'll do more prescribing over the next few weeks then. I'll tell the others to also do prescribing when they're teaching. Cool. You'll feel prepared by the time fifth year exams come along. By the time you come to finals, you'll be really good at prescribing, I guarantee it. Because I felt quite uncertain last year as well, and then this year I just did loads of prescribing at DGH, which is quite good. So let me know. So have a whoops spoilers. Go through the process and calculate the flow rate. I'll give you another minute. Does anyone need more time? Just say yes if you do. Okay, doesn't seem like anyone needs more time. What fluid infusion rate did people get? Even this, I did kind of spoil it and show the next slide. You can give it to more decimal places if you want than I gave. 69.2. Yep, that is the correct rate of infusion. Yeah. So yeah, around 70 mils an hour. You're gonna round it, let's be honest. Yeah, 69.2. Nantish, you've done some funky maths. Good. Everyone's getting roughly the same. Yeah, it's around there. 16, 68, depends how much you're rounding and depending what figures you're using, but around 70 mils per hour is what you're looking at. So these are like the rate, how you calculate for kids. So if the first 10 kilos, it's 100 mil per kilo per day. The second 10, it's 50 mils per kilo per day. And for the anything above 20 kilograms, you're going at we're going at 20 mils per kilo per day. So the total 24-hour fluid requirement is 1,660, which over 24 hours is around 17 mils per hour. So does this mean we do give fluids during the night for peds? Probably still no, but for exams, yes. In reality, I think giving fluids overnight in reality is just generally a bad idea because people toss and turn. People will pull out their cannula, things like that. It's just not really worth the risk, especially in kids. It's so hard to cannulate a child, and it's terrible for them. So you do not want them pulling their cannula out. So you're probably going to adjust it in real life. So I would so yeah, this is more for an exam thing. Like a lot of what we do, I like you probably realized this coming to the end of your second clinical year, but so much of what you learn at med school is not what you do in real life, and there's like good reason for that. I'm sorry, like I know that's probably the last thing you want to hear, but that is just the truth, unfortunately. What's the exam answer rationale for dividing rate by 24 hours? Don't want to overload them with fluid. Yeah, so the thing with kids is you prescribe one bag at a time. You do not prescribe a full 24 hours worth. You'll prescribe one bag, preferably like maybe 500 mil or a liter. You won't prescribe much, and then you review and you're like, okay, what am I going to prescribe next? You definitely do not prescribe a full 24 hours worth of fluid in one go. So just do one bag at a time for kids. Hence this question wasn't prescribed the next 24 hours worth of fluid. You would be asked to prescribe the next bag and then review them. In kids, yes, dextrose saline is the best for kids. Dextrose saline is generally the best fluid. But like it depends on what your trust has. I would probably like it depends what they have. Like it in an exam, if you want to go for dextrose saline, that's absolutely fine. I think that's actually not a bad idea at all. Glucose and potassium requirements are things that you would consult a senior doctor about in kids. You tend not to do it yourself. Same, yeah. So like electrolytes and glucose, I was never really taught about in fifth year, which to me suggests it's not really examined that much. I don't know. Have you been taught about stuff like that? I'm curious because I never was. I'm really hoping that wasn't just UCL neglecting a part of the curriculum because it wouldn't surprise me. Um, Yeah, I would just leave out the K plus and I'd ask a senior about it. But I haven't been taught about it, which is why I would ask a senior about it. If someone has been taught anything, please let me know what you've been taught. Okay, so it's a different chart for kids, and what you're gonna, but like if you were asked to prescribe this on the Good Hospital drug chart, you would probably give them a 500 ml bag of something like dextrose saline, or give them dextrose and then you can give them saline later. Basically, give them a 500 ml bag of something, and then you'd give it over. What would you give it over? You want it at around 70 mils an hour, so you'd probably just give it over around 7 hours or so. Yeah, that's why. Yeah, Christina's right. Like kids have really weird electrolyte requirements. It's really bizarre. So yeah, give them 500 mil of something over maybe 7 hours. There's a PowerPoint on pediatric prescribing on the CPP tab of Mod A. Yeah, you can cross out duration and put the rate. That's fine. You don't even need to cross it out. You can just put the rate in the box. That's also fine, because like the nurses are really good. Wait, so you wouldn't prescribe, say, 1 liter and then another 500 mil? I think giving it in smaller amounts over the day is generally better with kids, so you don't overload them with fluid. You wouldn't prescribe it as 1660 at 70 mil an hour. You would prescribe it as separate bags, and you'd like if they asked you to prescribe this, they would say give the next bag of fluid. They wouldn't say give all 3 bags of fluid. You prescribe 1 bag of fluid at a time. I remember specifically asking about this last year because I was super confused. And then you'd say give it a 70 mil an hour. You could give a liter, but I think giving a liter in one go when the total fluid requirement is 1.6 liters is a bit much. I think I would rather give 500s, but it's up to you. I don't think you'd be marked down for it, but because it is more nuanced, and like ultimately the thing about uh, pediatrics is almost everything you do as a junior doctor is vetted by a senior doctor because there's so much at stake. Yeah, we'll talk about fluid deficits next week. I think we should do more prescribing. I've got another prescribing case in this. I'll put it into next week. We can talk about fluid deficits in kids, and we can talk about this again. Yeah, so 500 mils at a rate of 70 an hour. That sounds like reasonable to me. Basically, there's lots of options. But yeah, that sounds sensible. As long as it sounds sensible, you'll get the marks for it. What if it's a kid with burns that's in palliative care? Joshua, go away. They're going to ask you that. So yeah, I was told the same thing as Ritika, that dextrose saline is the best fluid for kids. Dextrose saline is generally the best fluid, but like it's not always available. So in real life, you're probably going to have to balance dextrose and saline. If you combine, basically, dextrose saline is just like half 5% dextrose and half saline. 0.9% saline. So you can make it up. It's not really an issue. You could give a 500 ml bag of saline followed by a 500 ml bag of dextrose, and you have effectively the same thing. It's up to you what you do. As I said, if it's sensible, like this is why our exams aren't marked by computers. Like your prescribing station is not going to be like marked by a computer. It's going to be marked by a medical person, and this is why, because like you need to know something. Like there's so many correct answers for the purposes of exams. If you prescribe it in an exam, that's absolutely fine. You can just prescribe it. If you're happy with that, you can prescribe it. I've never that's fine. You can do that. That's okay. I actually doubt that they'll ask you to do fluid prescribing as an OSCE station for kids. I think it's quite hard. I think it's very nuanced. I'm going to stop the recording there so I can tell you some stuff.